Welcome to this evening's Immunisation Coalition webinar. Our topic this evening is human papilloma virus, a 2025 update. I'm Andrew Baird, and I will be moderating this evening's webinar. I'm a GP in Melbourne and also a member of the Immunisation Coalition. I would like to acknowledge the traditional custodians of the various lands on which we work today, and the Aboriginal and Torres Strait Islanders participating in this webinar. I pay my respects to elders past, present and emerging, and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and the waters of Australia. Presenting this evening's session is Angela Newband, who will be speaking for around 40 minutes. This should leave us with plenty of time to answer any questions or comments that you may have. Please type questions in via the Q&A button, not through the chat box, and you can do this at any time during the session. You'll find the Q&A button at the bottom of your screen. We'll try to answer as many questions as possible, and questions that are not answered, we will send responses to you over the following few days. Tonight's presentation will be recorded, so all participants will automatically be on mute for the event. At the end of this evening's webinar, you will receive a 2-minute evaluation form. Please fill this out so we can continuously improve the quality of the education activities. I'd now like to introduce Angela. Angela Newband is a nurse, an immunisation education consultant, and a member of the Immunisation Coalition. Angela has been involved in immunisation programme delivery in South Australia for over 24 years, originally as an immunisation provider, and then in programme coordinator roles within the divisions of general practice in South Australia. Also with the South Australian Health Immunisation Section, the Medicare Local Network, and the Primary Health Network until December of last year. Angela continues to provide clinical advice and nurse education across a variety of platforms, and she is passionate about vaccination and the role immunisers play in vaccinating the general public. Angela, thank you for joining us and welcome.
Thank you very much, Andrew, for that very, very kind introduction. I'm just going to share my screen if, that technological challenge isn't too great for me, which it usually is. Okay. So tonight, and look, I welcome you all. Thank you very much for spending your evening with us. Absolutely. We've got some learning objectives, of course, that we're going to be meeting. And they're listed there, but you've heard a little bit more about me. I would like to know a little bit more about you. So let's just check who has joined us tonight with this little quick poll. Thanks, Anastasia. So just indicate your profession or expertise in an area that closely represents your background, and we'll kind of know who we're talking to tonight. Give you a couple of seconds to do that. Fantastic. 27% GPs or medical practitioners, 65% nurses, midwives, immunisation practitioners. You've got some research or educators, a few pharmacists on board. That's fantastic. Some other healthcare workers as well, which is absolutely wonderful. So we've got a fair bit, obviously, to cover tonight. So we shall get ourselves right into it. We certainly know quite a lot about human papilloma virus or HPV. We know that probably about up to 90% of the population is going to be infected with at least one genital type of HPV at some stage in their life. people with persistent HPV infections are at risk of developing HPV-associated cancers. And the most common is cervical cancer in women. And because the virus is so common, HPV has often been referred to as the common cold of sexual activity. We know that HPV causes most papillomas, or more commonly known as warts. These are obviously quite benign. They only form in certain types of tissue, but however, these tissues occur all over our body. They can also form on the skin and in the surface of moist tissues inside the body, such as the gut or the airway. Our immune systems are pretty good and usually clears any genital HPV infections from the body within about a year or two. However, there are some HPV infections that are not successfully controlled by the immune system. And HPV infection can actually remain quite dormant for many years. And this really means that people that are in long-term monogamous relationships, or people who have not been sexually active for many years, can still test positive for HPV on a HPV screen. And this might be the case in around about 3 to 10% of high-risk HPV infections, and those, of course, can lead to moderate dysplasia and high-grade dysplasia that, of course, if it's untreated, may get worse over time and become precancerous and then cancerous, although not all precancers will go on to become cancer. Dormant HPV is not detectable on a HPV test. It only becomes detectable when the infection is active. So, for example, women who have undergone a cervical screening test may test positive for a HPV infection despite testing negative in earlier screenings. And this does not necessarily mean that they have contracted HPV since their last screening. It may just simply indicate that the infection was dormant at the time of their previous screening, but was active during the most recent one. And we do know that it can take about 5 to 10 years or more for HPV infected cervical cells to develop into precancers, and even longer, maybe 20 years to develop into cancer. We know that genital warts are also caused, obviously, by this HPV infection, and mainly HPV types 6 and 11. And this infection is mostly diagnosed, obviously, when warts are seen on physical examination. We also can see here that HPV causes the majority of cervical cancer cases, and is certainly responsible for many oropharyngeal cancers and anogenital cancers, particularly related to HPV types 16 and 18. And as we are aware, there are HPV tests that can screen for cervical cancer, but there are no approved HPV tests to find HPV in these other parts of the body. So more than 100 HPV genotypes have been fully sequenced, and the genotypes are differentiated by sequence variations of the major genes. HPV genotypes differ in their preferred site of infection, with approximately 40 HPV types specifically infecting the anogenital tract. And there's a whole range of HPV types there that you can certainly look up for yourself. We know that cancer, and particularly in this case, cervical cancer, remains a really major health concern. But then those additional cancers, cancer of the anus and the penis and the vagina and the vulva, are relatively uncommon, but are thought to be increasing in incidence. And this possibly is due to increasing HPV transmission secondary to changes in sexual behaviour. But the low-risk types, such as type 6 and 11, which are most commonly associated with the non-malignant lesions, such as the genital warts. For HPV to cause an infection, it really does require a breach in the epithelial surface, so it can enter the basal epithelial cells through endocytosis, and therefore that will cause the infection. However, infections are, the infectious virons really are only produced in those terminally differentiated layers of the epithelium. Evidence really has suggested that HPV progresses quite successfully because it does not induce an immune system response for most of its cycle. And there's a whole range of reasons for all of that. But certainly we just need to be aware that our body does not specifically recognise it immediately. So the incubation period, so that's the time from becoming infected to the time of developing some symptoms, is possibly around about 2 to 3 months, but it has a fairly broad range from 1 to 20 months for genital warts. The infectious period, so that the time during which an infected person can infect another person, that's actually quite unknown, but for genital warts, it's probably for at least as long as the visible warts exist. HPV infection doesn't often cause noticeable symptoms or any health problems. It's visible when you can see warts on the genitals, and they can look different for each person and appear in different parts of the body. Warts can be flat, or they can be raised, they can be single, or they can be multiple. They can form clusters like little cauliflowers. Subclinical infection is obviously where there is no signs or symptoms, but HPV is found inside the skin cells, and that therefore is still able to spread to others. There's really no current approved screening test for HPV in men. Certainly, if a man is concerned or has any questions, they really should speak to their doctor or medical practitioner. There's no cure for HPV. Obviously, removing the visible warts can happen, but it doesn't necessarily reduce the transmission of the underlying HPV infection. And about 80% of individuals with HPV go on to clear the infection spontaneously, like I said, in about 1 to 2 years. There are some high-risk types of HPV, and of course, including 16 and 18, and these can take longer to clear from the body. In some people, infection with these HPV types remains for a very long time, and there is a higher risk of developing significant cell changes or dysplasia, which can progress, of course, to invasive cancer if it's not detected and treated. It is reasonably rare for HPV infection to lead to cervical cancer, but if it does, it could take up to 10 years or more. Obviously, back in December of 2017, the cervical screening test replaced the old Pap test. The cervical screening test looks for HPV infection, HPV virus that can lead to cell changes in the cervix. And it's recommended for that screening to take place every 5 years. At the point where abnormal cells in the cervix bind together and form tumours, cervical cancer symptoms may then become apparent. And these are really the most common signs. But because many cervical cancer symptoms are also associated with other less serious conditions such as infection, women may not seek early medical advice. So probably the big take-home message here for you as a provider is to make sure women are aware of this. And if there are any changes to their routine body functions, then they should really talk to their GP. So we know that it's most commonly transferred from person to person during vaginal or anal sex. However, penetrative sex is not the only way that HPV is transmitted. It can also be transmitted through skin-to-skin contact during oral sex or other types of sexual activities. And a person with HPV can pass the infection to someone even when they have no signs or symptoms. So anyone really that is sexually active can get HPV, even if they have had sex with only one person. But the risk of acquiring a HPV infection increases with the number of sexual partners an individual does have. So recurrent respiratory papillomatosis can occur at different stages of life. The juvenile onset form of recurrent respiratory papillomatosis affects children really around the age of 4 years on average. It's thought to be caused by the transmission of HPV virus from mother to baby during childbirth. The risk of developing the disease is increased if the mother has genital warts that are active at the time of delivery. It is a rare disease though, but it obviously causes an exceptionally significant problem for these young children, because when a papilloma or a group of papillomas grow, they'll grow in the larynx. It can obstruct the process of breathing, and therefore the child or the infant may require frequent laser surgery to prevent the warts from blocking its breathing passages. Unfortunately, the papillomas will return after treatment. They may transform into a malignant tumour. So because of this, it really becomes necessary for this treatment to recur multiple times. Obviously, for little babies and young children that do develop respiratory papillomatosis, the symptoms include some hoarseness or a quiet or weak cry, airway obstruction, of course, in the severe instances. Like I said, HPV is so common that almost everyone that's sexually active will get HPV at some time of their life if they don't get vaccinated. La Trobe University in Melbourne surveyed about 6,500 secondary students in years 10 to 12 back in 2018 and found that around 47% of students in years 10 to 12 have had sex, defined as either vaginal and or anal intercourse, and that was regardless of the gender of the partner. Year 10s, though, were thankfully much less likely to have had sex yet. 34% had never had sex, compared to the year 11s and the year 12s. The average age for the 47% that had experienced sexual intercourse in the survey was around about 16 years old. So it is really important to get this vaccine into these young adolescents before they become sexually active. So there are a range of biologically based factors. The high rate of HPV prevalence among HIV-infected women is thought really to be due to the compromised immune system that's been caused by the HIV infection. And that sort of enables that viral persistence of HPV and probably increasing the possibility of contracting infections from multiple HPV genotypes. The age of the first sexual encounter in some studies have not really been related to HPV risk, but in other studies, it is associated with HPV prevalence. So other studies have certainly suggested that the older age of the first sexual intercourse was a risk factor for high-risk HPV infections and multiple HPV infections. So there's a whole list of risk factors for HPV just that are purely based biologically. But then there's also behavioural risk factors. And several studies really have examined these risk factors for genital HPV infection, and particularly the high risk types. And these high risk factors include that lifetime number of sexual partners, perhaps having a new partner, maybe not knowing the partner's sexual history. The high-risk sexual behaviour is the main risk factor associated with getting a HPV infection and the persistence of HPV infection and the development of HPV-associated cancers. Cigarette smoking has also been shown to be associated with HPV load, HPV prevalence, and incidence, as well as persistence. And this may be because of the ingredients of cigarette smoke has also been shown to modify the function of immune cells. So we've now got to be concerned a little bit also in regards to the e-cigarettes and the vaping and things like that. So there's a lot more research to be done, and we will be looking with very keen interest, but you know, we certainly know that vaping is not a safe alternative to traditional cigarette smoking regardless. So the crude rate of cancer is per 100,000 men or 100,000 women per year. The HPV and related disease summary report back in 2022 stated that around 41% of oral pharyngeal cancers, mainly comprising of the tonsils and the base of the tongue, were due to HPV, with HPV 16 found to be the most frequent type for those particular cancers. Globally in 2020, there were 600,000 new cases of cervical cancer and 340,000 deaths. Australia has one of the lowest rates of cervical cancer mortality, which is fantastic, but the death of 328 women is 328 women too many. So we really need to understand that this is one of the most preventable and treatable forms of cancer. But women must continue to get screened through the National Cervical Screening Program, and these adolescents must continue to be vaccinated through the National HPV Vaccination Program, which is generally run through schools. But other providers can provide this vaccine to those adolescents. So if they do miss it at school, please use the opportunity to vaccinate them. As previously highlighted, we know there's many types of HPVs, that could cause cervical cancer. But as we can see in this particular table, HPV type 16 and 18 are the most common cause. About 8.5% of women in the general population are estimated to harbour cervical HPV 16 or 18 infection at any given time. These are the current vaccine dose recommendations for the immunocompetent individual. So if you're seeing patients, like I said, that have not yet had their 26th birthday, please encourage them to receive this one single dose for free under the NIP. So the National Immunisation Program is there for them up until they have their 26th birthday. If someone wants to wait, or they have now gone over 26 years of age and they change their mind, then they're going to need 3 doses of vaccine. And each dose of vaccine is going to cost them anywhere from $220 to $260 per dose. So really encourage people to take advantage of getting vaccinated earlier before their 26th birthday. So why did the dosing change from a 3-dose schedule for these younger people up to the age of 26? So multiple studies found that a single dose of the 9-valent HPV vaccine provide similar protection against HPV types 16 and 18, just the same as a 2-dose or a 3-dose schedule did. So ATAGI, the Australian Technical Advisory Group on Immunisation, their recommendation really aligns with those of the World Health Organization Strategic Advisory Group of Experts on Immunisation, or SAGE, and the United Kingdom's Joint Committee on Vaccination and Immunisation, or JCVI. And the Pharmaceutical Benefits Advisory Committee, or PBAC, has endorsed this ATAGI recommendation. So it's just now a single dose for those younger people. A single dose is recommended obviously for the younger people, but immunocompetent people as well. But if somebody is immune compromised, then they should receive a 3-dose schedule for them, regardless of their age. And also, if they have turned 26 years of age, they also need to revert to that 3-dose schedule. We've got 3 other polls in tonight's presentation, and this is our first poll. And this is just testing you a little bit without having your handbook in front of you probably. But what is the minimum acceptable interval in a 3-dose HPV vaccine dose schedule? Now, I've underlined the word minimum to give you a little bit more of a hint. Let's see how you go. Is it 3 weeks between dose 1 and 2 and 16 weeks between dose 2 and 3? Is it 4 weeks between dose 1 and 2 and 20 weeks between dose 2 and 3? Or is it 3 weeks between dose 1 and 2 and 16 weeks between dose 2 and 3? Or is it 4 weeks between dose 1 and 2 and 12 weeks between dose 2 and 3? See how you go. How did we go, Anastasia? It was a little bit of a difficult question, because I know that all of you would go straight to the online version of the immunisation handbook and seek this answer before giving any doses. So for people who are immunocompromised at any age, or if immune competent and have started the HPV program at over 26 years of age, the answer is actually D. So 53% of you did very, very well. So bear in mind, this is the minimum interval between doses. But also remember, the minimum interval between dose 1 and dose 3 is 5 months. The recommended intervals between doses is 2 months between dose 1 and 2, and 4 months between dose 2 and 3. Right. So it was a little bit of a trick question, but the immunisation handbook is there to guide you. So who else should we vaccinate? And certainly studies have demonstrated that men who have sex with men are more commonly affected with multiple HPV genotypes and tend to take longer to clear the infection. They also have a slightly higher incidence of high-grade anal intraepithelial neoplasia and anal cancer than the general population. And some overseas studies have found a greater than 30-fold higher increase of anal cancer in men who have sex with men than in other men. Adults that are over 26 years of age who have been diagnosed with or have a history of HPV-related precancers or precancerous lesions may be considered for vaccination because of their inability to clear and control the HPV infection, noting that vaccination protects against future infections and does not have therapeutic effects. So, we'll talk about that in a little minute. Chronic immunosuppression for, various reasons really is a really important risk factor for persistent infection of HPV and HPV-associated disease, because the immune response is likely to be lower in an immune-compromised person than in a healthy person. And therefore, certainly a 3-dose schedule is recommended for them. We've now got another poll. So, is routine HPV vaccination recommended for all adults 26 years and older? Is it A, no, they are not routinely recommended to receive HPV vaccination because there are circumstances where vaccination is recommended or could be considered? Is it B, yes, absolutely, all adults should be routinely vaccinated with HPV vaccine? Or no, routine vaccination should be started at 17 years of age? Or yes, adults can be given an oral dose or an intramuscular dose of HPV. This one you may find just that little bit easier. How did we go, Anastasia? Yes, absolutely. So the answer is definitely A, and 83% of you are definitely on board. So adults aged over 26 years of age are not routinely recommended to receive HPV vaccine. However, as we know, some adults may benefit from HPV vaccination. So when you're deciding and having that conversation, we have to consider, what is the likelihood of previous exposure to HPV? And what are the future risks of HPV exposure and HPV disease? Note, please, that all men who have sex with men, including those aged over 26 years, are recommended to receive HPV vaccination. And all adults aged over 26 who have been diagnosed with or have a history of HPV related precancerous or cancerous lesions may also be considered for vaccination because of their inability to clear and control infection. So we certainly know that it's not routinely recommended for those over 26 years of age. So these are the two inactivated HPV vaccine types that we have available here in Australia. HPV, the 9-valent HPV is the one that is funded through the school program, if you like, for these young adolescents. Both of these vaccines are recombinant protein particulate or virus-like particle vaccines, and they both contain that major capsid L1 protein of all of these HPV types that you can see listed there. So it's not a live virus vaccine. They are not live virus vaccines. So HPV vaccines really stimulate the body to produce antibodies that in future encounters with HPV, they will bind to the virus and prevent it from infecting cells. The current HPV vaccines, as I mentioned previously, are based on virus-like particles or VLPs that are formed by HPV surface components. VLPs are not infectious because they lack the virus's DNA. However, they closely resemble the natural virus, and antibodies against VLPs also have activity against the natural virus. The VLPs have been found to have really strong immunogenic properties, which means that they induce really high levels of antibody production by the body, and this makes the vaccines really highly effective. So while the available prophylactic vaccines can protect against infections by the most common high-risk HPV types, they are not able to eliminate or prevent the malignant progression of persistent HPV infections. So all Year 7 high school students across Australia are offered this vaccine. Unfortunately, the uptake is suboptimal. By the end of 2023, the 2024 data is not yet available to us, but by the end of 2023, uptake for females was at 82.5%. And at 76.8% for males. Now, this is when they were assessed at 15 years of age. So many of these adolescents are missing out on this dose of vaccine. So if you are seeing them in your practices, please check the AIR. If you cannot see that a dose has been given, please opportunistically vaccinate them. Clinical trials and limited data from observational studies where HPV vaccine was inadvertently given during pregnancy indicate that there's actually no increased risk of adverse effects on the pregnancy or the fetus. However, HPV vaccine is not recommended in pregnancy. So if a woman does become pregnant during a course of HPV vaccination, it's just recommended to stop the program and just complete it after she has delivered the infant. You don't need to restart a course. If there's evidence of the course already started, there are evidence that doses have been given, you always just build on the vaccine course. As with any vaccine, an anaphylactic reaction to a previous dose or a component of the vaccine is an absolute contraindication for further doses. So this is our last poll for the evening. So HPV vaccines are not recommended for pregnant women because A, it's a live virus vaccine, or B, there's an absence of evidence of vaccine use in large populations of pregnant women, or C, vaccination in pregnancy has been proven to cause spontaneous abortion, late fetal death, and congenital abnormalities in infants. And D, pregnant women are at higher risk of anaphylaxis when vaccinated in pregnancy. This one, I think you will find you will do well. Okay, Anastasia, how did we go? Okay, perfect, perfect. 90% of you, well done. Of course, the answer is B. There was certainly, you know, at the time of conception or during pregnancy, they should be really reassured if the vaccine was given during, you know, that really early time frame of the pregnancy, because the evidence doesn't suggest that it harms the mother or the fetus. And in fact, there was a pooled analysis of women who actually became pregnant during the clinical trials of the 2-valent as well as the 4-valent HPV vaccines that overall showed that there was no differences in pregnancy outcomes amongst those HPV vaccine recipients and the control vaccine recipients. But, you know, as a precaution, women who become pregnant, you know, during a course, we would just stop and continue once the baby is born. So despite advances with HPV vaccine, it's still really essential that individuals between 25 and 75 years of age who have a cervix, who have ever been sexually active of any description, should continue to have cervical screening testing. Anyone eligible for cervical screening test has the choice to screen through a self-collection of a vaginal sample that's using a simple swab, or a clinician may collect a sample from the cervix using a swab and a speculum. The self-sampling HPV has been proven worldwide to be really accurate for HPV detection, and that it actually has caused an increase in people participating because it's a lot more convenient. They can do it themselves. It's a lot less painful and a lot less embarrassing for women. So there's really strong evidence that the HPV vaccination program is working. It is preventing cervical precancer lesions in young women. And this has been published in a collaborative study. And this study also found that vaccinated women, the ones that had had all of the doses recommended to them in those school cohorts, have about a 48% lower rate of the most serious precancerous abnormalities than the unvaccinated women. But it's certainly expected that, you know, over the years to come, the effect of the vaccine will certainly increase, you know, because we're giving it to these young teens, preferably before they've had any sexual encounters. So the first randomised controlled trial of a single dose of HPV vaccine efficacy was undertaken in Kenya, and the trial showed greater than 97% efficacy against persistent HPV 16 and HPV 18 infection at 36 months among women in Kenya. And successful long-term HPV single-dose studies have also been undertaken in Costa Rica and India. So, like I said before, HPV vaccines are highly immunogenic. Clinical trial showed that the efficacy of one dose of the 9-valent vaccine against persistent HPV types was at 97.5% in young women aged 15 to 20 years. It's currently unknown if immunity following HPV vaccination is lifelong, but it does appear to be long-lasting. So we just need to wait for further evidence as time goes by. So cervical high-grade abnormality incidence rates are certainly decreased in the vaccine-eligible age groups by about 48% in 20% of and 20% in females aged less than 20 years and those aged 20 to 24 years respectively. So in 2022, there were 222 deaths in women with cervical cancer in Australia, which accounts for 1% of all female deaths from cancer. In addition to this, there's also been a remarkable decline in hospitalisations for anogenital warts in Australia, a decline from the pre-vaccine period, which was the 2002 to the 2007, to the post-vaccine period, the 2008 to the 2017, of around about 74.5%, and that was in individuals aged 10 to 19 years, 54% in the 20 to 29-year-olds, and 22% in those aged 30 to 39. And this is consistent with evidence of decreases in the incidence of anogenital lesions seen in outpatient settings and such as the sexual health clinics. So this vaccine program is working, but we must keep vaccination rates high. It's a well-tolerated vaccine. As with many other vaccines, there are some minor side effects that are self-limiting, very, very similar to what we see across all of the vaccine programs. So obviously there's been some myths and there's been a lot of controversy, but despite some controversy in social media and in certain populations, studies have really shown that there is no impact on human fertility following HPV vaccine. Some websites report really disturbing claims that one of the ingredients of the vaccine, which is polysorbate 80, causes infertility in rats. You know, this was really based on one study of newborn rats that were given an extremely large dose of Gardasil vaccine, so 20 to 200 times the human dose when it was injected into their abdomen. But the TGA have certainly reviewed all of the data and concluded that there is no evidence that the amount of polysorbate 80 in HPV vaccines poses a risk to human fertility or reproduction. We know that polysorbate 80 is used in other medicines and vaccines as well. There was also some talk around HPV vaccine being linked to autoimmune disease, but there does not have any real effects. An analysis of several clinical trials involving more than 20,000 participants found that the overall proportion of participants who reported new onset autoimmune conditions was really similar to those who got the vaccine and those who got a placebo. Certainly, there is no evidence to support HPV vaccine is a particular trigger of complex regional pain syndrome, more than that rarely seen for other painful stimuli. Similarly, POTS occurs irrespective of vaccination, and preclinical and clinical studies have found no evidence or basis to suggest a causative relationship between POTS and HPV infection. So just to summarise nice and quickly, obviously it's a common infection in both males and females. It can cause cancer in the anogenital tract and the oropharyngeal region. There's many, many types. 16 and 18 are the ones that we are most concerned about, and the most HPV-related cancer-causing types. But my plead to you as a provider is encourage people that do have a cervix to be screened and to check the AIR at every encounter and opportunistically immunise. So please, and thank you, please do this and get these rates up in these younger people and ensure all of those doses are put through to the AIR.
Angela, thank you so much for telling us all about HPV and HPV vaccination. Learned a lot and covered a lot of ground. Thank you for the polls as well to keep us engaged, and that was good fun and very useful too. So, and I think your take-home messages, and see if I've got this right, is encourage screening and check AIR, and I think we'll be on the right track there. We've got many questions, and we're not going to get through these, and they're fabulous questions. Some are about practical management of vaccination, some are more of the theory, but Anastasia has very kindly filtered and has given me a short list of questions. So let me start off, and we'll start off with a condom. So the question is, does the condom protect against transmission of HPV? And if not, what can be done to protect against transmission?
Okay, so the best thing to protect against transmission is just not have sex. That would probably be it. But a condom does not protect against HPV transmission because it is a skin-to-skin contact, and the condom only covers a certain part of the anatomy. But very useful for the prevention of perhaps some other STIs.
Thank you, Angela. That's very helpful. Another question about this time in regard to HPV being shared. Can it be shared in its inactive state or only when it's active and detectable?
Look, this is something that needs to be researched a little bit more, because I was sort of looking for the answer to this question. And what I tended to find is that they are unsure really about that, because they are currently researching couples where HPV infection is being shared between. And if somebody has got an active HPV at the time, the partner doesn't seem to be testing positive, etc. So there's a lot of work to be done in this space, realistically.
Watch this space.
Yeah.
You mentioned respiratory papillomatosis, which sounded potentially quite horrific. And the question is, are there antivirals that can be given to improve outcomes for this condition?
Not that I'm aware of at all. There are some reports that suggest that delivering the baby by a cesarean section may lower the risk of HPV transmission to the baby if the mother has, genital warts. But it doesn't completely eliminate the risk to the baby. So there are babies that are still being born by cesarean section that are, having, recurrent respiratory papillomatosis. So it's not anything foolproof, but I am not aware if there's any antivirals available for it.
And now changing theme to cigarettes. And the question around the cigarettes, you described the increased prevalence in cigarette smokers. The question is that something inherently due to the behaviors associated with cigarette smoking, or are there toxins in cigarette smoke that enhance the effects of HPV?
Yeah, look, there's reasonably good evidence that I can find to say it's the ingredients in the cigarettes and the cigarette smoke that are doing more of the harm. So you may have somebody who is not sexually active but is a smoker, but when they do become sexually active, if they do get a HPV infection, then yes, they could take longer to clear it, and they could be more prone to picking up more than one HPV type.
So I guess you call it a co-carcinogen, that it's them both, something like that. Yeah. This is a practical issue with sort of national immunisation programme and the state jurisdictions. But do you have to be a Medicare card holder to have the free HPV vaccine?
That's an excellent question, and I'm really sorry to actually say that yes, you do have to have a Medicare card. The vaccines, all of the vaccines that are listed on the NIP, the National Immunisation Programme, are linked to Medicare eligibility.
Thank you, Angela. So if you want it, you're going to have to pay, and you've outlined what the costs were. Question now, so for a person who already has HPV, what protection will they get from being vaccinated post their diagnosis of HPV?
Absolutely. A lot of people don't know which serotype or what genotype that they have been infected with. So we would assume quite strongly that they have not been infected with all 9 of the serotypes that Gardasil 9 will protect against. So it is still worthwhile vaccinating people, even if they have tested positive previously for a HPV infection.
Thanks, Angela. And just again on that sort of theme, you mentioned about vaccinations for people over the age of 26. If a person has no risk factors at all, but they're in their 30s and they want to be vaccinated just because they want to be vaccinated, is it okay to vaccinate them?
Absolutely, because their personal situation or their social situation may change at any moment. So even if they don't have any risk factors and they're not currently having any sexual activity, this is the ideal time to be vaccinating them, because we need to get this vaccine into these individuals before they have a HPV exposure.
Yeah. And in regard to administering the vaccine, can a live vaccine be administered at the same encounter, or does there have to be a gap?
No, absolutely, because HPV vaccines are not live virus vaccines. You can very, very safely be giving any other vaccine on the same day. We would always suggest where possible in separate limbs, but yes, they can certainly be co-administered on the same day.
Great, thank you, Angela. And we're approaching the end of the evening, and here's a great question. Somebody who's very forward-looking and saying, screening, why stop at 75? We're all living longer. Why don't we stop at 90 plus? Surely it's better to test and prevent.
Yes, that's the thing. Look, I've often thought of the same thing myself. Why do we have this upper age limit, really? I don't know the actual answer. I don't work for the Cancer Council, and I don't understand the processes of why. But in my simple little mind, I'm just thinking that HPV cancers take many, many years to develop. So if someone does test positive for a HPV at 80, they may well be dying of natural causes before they'll even get a cervical cancer anyway. But that's in my own simple mind, so don't quote me on any of that.
Yeah, I suspect you're right, because that's the answer for mammograms and for colorectal cancer screening, that there's a slow lead-in until pathology causes clinical disease. So and I think there are health economic arguments. So I think a really good answer to that is it's complex.
Yes, for sure. Absolutely.
Angela, we've come to the end of our evening. We're now at 7 o'clock. It's been a fabulous hour. We've learned a lot, and we've had a chance to discuss and talk about it. So that's been excellent. And I think there's been a considerable amount that we'll be able to take back to our practices and discuss with our colleagues, which I think will spread the word about HPV and its prevention. So thank you very much, Angela. It's been a fabulous evening. Thank you. And to
you.
our participants, many thanks for being involved and for your silent participation and for your questions as well. And the questions that have not been answered will be answered. We'll put them on the website a bit later on with our comments as well. Our next webinar will be the 2025 influenza webinar, and that's on April the 2nd at 6 o'clock in the evening, Australian Eastern Daylight Time, and it'll be presented by Angela Newbound. So, and the registration details can be found on the Immunisation Coalition website and in the weekly newsletter. Everyone, thank you. Good evening. Stay safe and see you next time.